I'd like to thank Ellie for inviting me to speak. I am a virgin to leg club, so as you will understand, I don't do leg ulcers. I always say my patients heal with a scar. They don't go on forever with manky wounds. So you can see I'm not really a leg ulcer lover. However, a lot of my patients who have burns already have existing leg ulcers. So my session today, although Learn Not to Burn, I really want you to focus on looking at your patients and the other risks they have. I have, if you don't know what my job is, I have the world's best job. I'm supernumerary, interfere where I like, have no budget, have a brilliant boss, and I only see nice patients. And by virtue of that, they're always nice. I'm called 5 Counties Fowler because our service, as you can see on the left-hand side here, is covering 5 different counties from Oxfordshire, Buckinghamshire, Berkshire, Hertfordshire and Bedfordshire. So I do a lot of travelling, but as I say, I have the world's best job because I go out to see patients in their home. So most of my patients are elderly, frail, have mental health disorders, sometimes are prisoners, which are particularly challenging, but predominantly are the elderly patients. My role is to provide that seamless service from the patient, from the burns unit to home, or maybe from the home to prevent them being admitted. And I'm used by community services who get me to come in and to save the patient a journey, because often there's a lot of mileage in that if they have to come to the hospital. So my agenda for you for the next sort of 50 minutes is identify the risk factors for the elderly population regarding burn injuries, make you understand the principles of minor burn wound management that you can manage and what you should be referring. My agenda is to keep you awake as I'm the middle one before lunch, and engage you in accident prevention. So if you are looking after elderly patients, leg ulcer patients, if you have students who go, I don't know what to do with the patients, because they all talk like that in Buckinghamshire, then you can say, oh, I suggest you go off and discuss risks in the home and hazards. And so I love having students. I always tell people I think of them as my personal slaves. They keep you up to date. They know how to do literature searches. They're at the pinnacle of their career because they're used to looking for information. And they want to share it with someone. So they keep me on my toes. I can also deliver care. They can document it, or they deliver the care and I document it. So I love having students. So I think if you have students, you can keep up to date much more easily. Now this study, the reported epidemiology of burns in the United Kingdom is from 2001. It has been repeated but not published, but the statistics are virtually the same. Approximately 250,000 people get burnt each year in the UK. More than 90% are preventable. But unfortunately, most of the burns happen to men, and I know men are really stupid, and they repeat the same things over and over again. And I can say that because I've got the data to prove it, so you can't argue with me, chaps. There was a consultant in Wrexham A&E who told me, in Wrexham A&E in North England, that, in North Wales rather, that because my feet are slightly smaller than men's, that enables me to do the washing up. So between that and going to Sainsbury's, I have less chance of getting burnt. So I'm just balancing the argument, so you don't think I'm completely sexist. But most burns are preventable. Out of those 250,000, 175,000 go to A&Es or emergency departments. So there's a big amount of patients who are either self-caring or looked after in the community who never touch hospitals. And out of those 175,000, 13,000 are admitted to hospital with the primary diagnosis of burn. And our wish in the burns community is if that patient has primary diagnosis of burn, they should be in a burn service. They should not be in a DGH or a community hospital without any burns team support. So always think of that if you meet someone with a burn. And out of those 13,000, about 1,000 require fluid replacement therapy, and those are the ones who need to go to burns units or burns centres because they're at risk of dying from hypervolemia. So I'm not going to talk about major burns, I'm just going to focus on the minor. Oh, sorry, going backwards. In the London South East Network, which is I'm a part of, we're all part of networks of care for burns. We see about 5,000 patients a year in our 4 services that we've got there. So those are the ones who actually touch our burn services. When we look at what the background is to burns in the elderly, most of them, 30%, are neglect, self-neglect. 10% are victims of abuse. And it's a frightening statistic that 1 in 20 elderly people will be subject to abuse. It's a statistic my mother knows very well, and that's why she doesn't live with me, because she would be that one. And if you'd met my mother, you'd know why I say that. She's like a shorter, smaller, more vitriolic version of me. And out of the statistics from the fire brigade, 143 people over the age of 65 died in fires to which fire brigades were called. So often people are scalded and the fire brigade aren't involved, and they may well be part of the fatalities, but you don't get those statistics. So although we know the rate for severe accidents is actually lower in this age group, and it's over 60, I hate to say, looking over that side of the room, we've called 60 as elderly in burns. When I was on the National Burn Care Group, we originally said 70 was elderly because there were a lot of consultants in their 60s. Now they've retired, we've whopped down the age to 60, so I'm getting worried now because I'm in my 50s. But the worry is that the highest risk for fatal injuries from scalds is 4 or 5 times more in the elderly than it is in children. So it is more complicated. You can't just say, oh, they've got a small burn and they're elderly. Those are the very ones who don't have the physiological background to support them during the stress of the burn injury. So a small burn could be fatal in someone elderly. So think about that when you're assessing your patients. And frailty and poor health of the victim are often the contributing factors. So why do I care? Not why am I in nursing. I came into nursing because I wanted to be needed. That's what I always said at job interviews. In reality, I was young and I wanted to see naked men. But, you know, you can't say that in a job interview. However, I've been doing it for several years. This is one of my favourite, I know you're not supposed to have favourite patients, but this lady has been in our care since last December. I'll call her Betty, but that's not really her name. She's morbidly obese, lived in a warden control flat, had carers 4 times a day, fantastic supportive daughters who lived some nearby and others further geographically. And she was mobilising just to the shower and then to her sitting room. So it's all a very small apartment that she lives in. And unfortunately, she fell over and scalded her chest with food, a hot fluid, but she fractured her femur, which you think that's not so bad, but the trouble is she had a knee replacement. So her burn was the reason why she got referred to us, but in fact her fracture was the complication. So she had to go, they had to weigh up the risk of theatre. So they took her to theatre, positioned her leg in the position that she wasn't allowed to bend it, move it for 3 months, and came back to the burns unit. And of course her burn was small, and at the time we felt that that wasn't really a priority to graft, because if she had not had the fracture, we would have managed her at home with my care. But unfortunately, because of the fracture, she had to stay with us, and she couldn't go to orthopaedics because we knew, and I hate to say it, orthopaedics has a fast turnover. They don't want someone on bed rest for 3 months who's morbidly obese. She came in with category 2 pressure ulcers, which healed in our care. We worked with her family, with her, with the physios, OTs, our psychosocial team, so we could move her as much as pain and her temperament would allow us, because she was very verbal about what you could and couldn't do. And she's still in our care now because the fracture finally healed. She cannot mobilise. She is bedbound now, but she's gone home, which was her goal. And my goal was we would have a bottle of champagne in the fridge that I would open the first time I went to see her at home, which we did. I didn't drink the whole bottle, all right? I did leave some for the family, but that was our goal, our shared goal, that we were going to open this bottle of champagne together. So she is at home. We did eventually graft her just to, you know, close the wound up because it was frustrating for her. But last winter, we realised, as we sat in a team meeting, that 1/3 of our patients' referrals over the winter months were elderly above 60, and out of those, half who were referred last December had leg ulcers. And it was things like they were leaning with their foot up on the fire, or they didn't have, what do you call them? I can't think of the word. Fire rails, you know, guards. They'd fallen asleep because of their medication and their bandages had got burnt, but they thought, well, it doesn't matter because the district nurse is going to come next few days. So they didn't report them. One lady went to the dentist to have her tooth out. She was 90. And he looked down and he saw fluid pouring out the bottom of her shoe. And she said, oh, don't worry, I've got a leg ulcer. And he said, no, there's more than that. And she'd actually burnt herself on top of the leg ulcer, but hadn't told anybody because she wanted to get a tooth fixed. That was more important than her leg. Another patient was found in Sainsbury's wandering around shopping, and the practice nurse thought, you know, when you look at legs, you never look at their faces, do you? You think, I know that patient. And she looked up and she said, but you were healed. And he said, oh, I've had a little wound. And she said, no, it can't be a little. His legs were wet to the knees, and although it was snowing outside, it wasn't that deep. So she finally persuaded him to go to the clinic to see her the next day, and it took him a further 2 weeks to allow him to come to us. And he nearly lost his legs because he didn't want to complain, he didn't want to make a fuss, he was fine. So I sat in a team meeting with my social worker saying, what are we going to do? And my consultant said, go on, Anne, go and report to the press, because I get on my little soapbox. So I spoke to the local press, and hence the photo of me and Betty, because I wanted to raise awareness in the local population about risks to the elderly with burns, hence learn not to burn, because they are a vulnerable, seriously at-risk group, so I really want to increase awareness. So my plea for you today is whether you work in acute, community, leg clubs, leg ulcer clinics, wound care clinics, try and raise awareness about burn prevention and accidents in the elderly. Because you've got to remember, people, my mother, this is not my mother, I hasten to her. Elderly patients are not just older adults. They're not just grey-haired 30-year-olds like you think children are just small adults. They are different both outside and on the inside. And as Bette Davis said, old age ain't no place for sissies. We know people live longer. They are not all going to be healthy and wealthy and wise. They're going to be living in poor, impoverished circumstances, and they will get burnt. I like this quote. Frailty is like pornography. It's hard to define, but you recognise it when you see it. Most of my patient group are elderly, and they are frail. And the most risks, particularly when we look at fatal burns, is careless smoking, especially in the bedroom. Now, that's not after prolific sex like we all have, but that's because they are either bedbound because of illness, ill health, and for them, their quality of life is having a cigarette. They're not going to stop at 88 or 95. They don't want to live longer. Doesn't mean they'll be happier, does it? It's just be more miserable without the cigarettes. Most of the patients won't have a smoke detector or a functioning smoke detector. So again, if you're doing home visits, those are things you should be looking at. In the wintertime, we do have more heaters. And in places like Northern Ireland, Scotland, there are more open fires, so hence there are more risks. They may drink while they're in bed, and then they fall asleep with the cigarette on the bedding. They may have electric blankets, which has been a major problem, and the fire brigade have been trying to raise awareness with this for the last few winters, that are poor quality. Nobody's checked them. They've had them there for years, and nobody's looked at them. They may have excessive hot water. We want people to have thermomixer taps because otherwise it's too hot when they bathe. Most of our patients who are elderly don't like showers. They get admitted to the burns unit, bless them, and they have daily showers. It's a bit of a culture shock. And my role when I go home is to give them a therapeutic bath. Because district nurses don't bathe because that's a social need, and carers don't do dressings because that's a nursing need. But I go in and I am martini specialist, anytime, any place, anywhere. I wash their hair, I cut their nails, I polish the nails, I do the dressing, I tidy them up, I make them look and feel better. That's my role. I know it's the best job in the world. I know you don't have the time, but I do. And things like they use excessive heating when cooking with oil or butter, particularly patients with Parkinson's who are trying to manage with a walker and they're in the kitchen. They can't move as quick and something flashes up and it catches their sleeves because this is not the ideal clothing to do cooking in, is it? They've also got reduced sensory and cognitive abilities, so they can't smell if something's on fire. They may not feel the heat of the radiator when they're sitting next to it. They may not see very well. They may not hear the smoke detector when it goes off. A lot of patients have underlying medical conditions, whether it's dementia, whether it's depression. They may have slower reactions. They may be completely inactive. And I was telling Professor Foster earlier, one of the worst cases I had to deal with in my career in the last year was an elderly lady who was deaf, blind, and demented. And myself and the matron used to cry after doing her dressing because it was so distressing. But we did it together because we didn't want all the staff to be involved and get distressed. But then she would allow us to comfort her. We could hold her, cuddle her, and give her little toy, which was her comforter. And what it was, my psychologist kept saying, don't worry, Anne. You know, if she allows you to comfort her within, a couple of hours, she'll have forgotten. But, of course, the patient recognised my perfume. When I went in, odour hospital and nicotine, she would recognise my smell. So I had to start changing my perfume so that she wouldn't recognise it when I went to see her. Things like prescription drugs, one of the problems, one of the patients I had, she kept complaining that she had diarrhoea, she felt faint. GP had put her on an oral antihypertensive and nobody had reviewed it. She actually collapsed in the bathroom against the radiator and nobody found her for several hours. So if patients are saying, I don't feel well since you put me on this tablet, listen to them. It's really vital you listen to your patients. And a lot of our elderly patients don't have the financial reserves to improve their environment. They may be using inappropriate portable heaters. They may have bad electric blankets. They've got older homes, poor wiring, so they're at a higher risk. So the most common burns we see in the elderly are scalds from hot water, things like hot water burns, which is a contact burn on the back. I love hot water bottles, but please, please, if patients use them, remind them they're supposed to take them out the bed when they get in the bed, not cuddle up with them. Things like falling asleep in open fires, being burnt from scalding water, electric fires, and generally house fires because of poor wiring or even dropping cigarettes and not making sure they're extinguished. There are risks, as we know, physical and mental changes. I love the one of understanding. I thought they were doing the thumbs up until I looked at it closely. Just make sure you're still awake, guys, at the back. They have poor mobility, poor sight. They may be on medications. And also, it's the understanding and attitude. Oh, it won't happen to me. I've lived till I'm 90. I've never been injured in my life. I've been smoking in my life. Why should I stop? I would agree with that. My dog would make me up. Not if they've been overcome with the fumes and they're dying of a smoke inhalation. And the other one is, we've got the best fire brigade in the world. They'd save me. Well, we have got better fire and rescue services. They've got better breathing apparatus. But they can still have a significant injury. So we know that they can't move, they can't see, they might not be able to put the fire out, they might not be able to get themselves out the burning house. They've also got decreased sensation, often because they're diabetic, and they've got lack of awareness, and also their wounds are covered sometimes with compression bandages, so they actually don't think about it. They'll say, I knew the nurse was coming in a couple of days, so I didn't say anything. And our patients, on our written literature we give them, we say, if this happens, contact us. Because patients used to say, when we did audit, they come back after a week and their wounds were rank, foul-smelling, and they go, well, I didn't want to bother you because I knew I had an outpatient clinic appointment in a week. That's what patients talk like in Buckinghamshire. But, sorry, going backwards. We know that there's physiological aspects of ageing. Once you're over 30, you're on a hiding for nothing on that table. Once you're over 30, everything slows down. It takes longer to heal. So we know the tissue's thinning. We know everything decreases, the touch receptor, pain receptors. There's delayed growth with tissue. So if they get a wound, it's going to take longer to heal. It decreases the healing rate of a partial thickness burn, which we would expect to heal within 2 to 3 weeks. If it's somebody elderly, frail, and they've got a burn on the lower leg, it may take 7, 8, 12 weeks. So you have to adjust it according to the patient. Worse is all the aspects physiologically for breathing. So they're going to often increase risk of chest infection, pneumonia. And as I said, the lady I looked after who was so complex, she survived her burn and then a month later died of pneumonia. So we got her over that, but she didn't get over the stress completely of the injury and then succumbed to a chest infection. There are different tools you can use. For the pre-hospital professionals, the Geriatric Society in America have the GEMS diamond, which is very handy, so a paramedic goes in and can assess someone. I'll talk a bit about it briefly. And the National Initiative for the Care of the Elderly, which for us is quite funny because it's nice in Canada, has respect all. So if you're caring for an elderly patient, it's aspects of care. It's not, a tick box, and it's not to replace your ABCs of fundamental care, but it's an aid memoir. We know we have national service frameworks for the elderly for different conditions. And again, your students, your personal slaves, can go out and get that information, feedback, utilise it in your department, share that information with you. So GEMS stands for geriatric, I know it's not a pleasant term, but older patients, this is for a paramedic going into a home, may present atypically, so it doesn't mean what you've necessarily been called for is what's the condition. Environmental, look around the patient's home and see what is the clues about what's happened to the patient. Get a thorough medical history. So it's not just looking at here and now, but what medication they're on, what have they suffered in the past. Social assessment. Most of the burns patients who we see who don't do well have no social network. All burns patients throughout the ages do well if they've got a supportive family and friends, even if it's a church network or a neighbour. But elderly people who live on their own, who have very little contact, don't do well because they don't have that social network. They may need assistance with activities of daily living, and they need information leaflets about what is available. So it's handy if our paramedics can at least say to the patient, you contact this social agency, you contact UK, Age UK, that the patients suddenly they have information. And I must admit, being very biased, women do live older, but women are more prone to utilising groups and support groups. Men aren't. So what I try and do is encourage the local volunteers to contact that patient so that they have that initial break the ice and meet them. Because a man won't tend to do it. A woman may do it, but a man won't. But that's just personal observation, Fowler, 2013. When you look at respect all, I love this because you're assessing your patient, looking at recreation, what things do they do, what helps them, what doesn't help them, their environment, sharing the care with the patient, their relatives, family, support network, making it person-centered, making it relevant, educating the patient. I mean, it's just headings, all right? There's a lot more behind this tool. Communication, we know, is the lifeblood of everything we do. And you can imagine I'm very quiet, shy and retiring. I don't communicate very well with my patients. I love my patients to death, or even recovery. But I love keeping in contact with my patients. Some of them call it stalking, but I call it, caring for the patient. You want a total picture of your patient, not just because they've got a burn or a leg ulcer, but the whole picture of what makes them who they are and what helps them through their day. So assessment is key, drives your management. Listen, and I love that quote about with GPs, let the patient say what they need to say. Don't interrupt them when they first come in. And we are so busy trying to get everything ready. I'm not. I have all the time in the world. I don't have 15 patients in a day. I'm not in a clinic, but in a home situation, it's totally different. I never rush. I just say to patients, you'll see me in the morning or the afternoon. I never give them a specific time because I drive so far. But whenever I'm there, I'm with them for that time. They are mine. They might not want me there for that length, but I'm there. And encourage them to look after themselves and make the best of themselves. So this poor gentleman had a stroke, collapsed in his bathroom. Nobody realised he burnt his foot on the radiator. Now, if it had been the dorsum of his foot, wouldn't be a problem, but it's the plantar aspect. So once they're starting to mobilise him in the stroke rehab unit, he's putting pressure on his burn wound, which is actually a bit like tissue anoxia with pressure. It's reducing the capillary blood supply, and therefore it's going to take even longer to heal. So those are sort of patients that would stay in the stroke unit, but I'd outreach to them. This poor lady lived on her own, had dementia. Fortunately, she'd rung her son to say, oh, I'm seeing you later, and he thought, no, you're not. But anyway, he thought, I'd better go over and check on Mum. She got out the bath, and then as she went to dry herself, sat on the bath and fell backwards into the bath. And she had the double whammy of scald from the hot water that was still there and the pressure of lying in the bath that her son found her 2 hours later. This is my lovely lady who has been this is her lying on her side, and who was on antihypertensives, fell in her bathroom against a radiator like this, because there are such old radiators around, and sustained a really nasty full-thickness burn, which she did not want grafting. She'd had terrible experiences in hospital previously. She wanted to limit the time in hospital, so we managed her at home for a long time before even I gave up, and we had 2 recalcitrant areas that wouldn't heal, and we grafted. The donor sites, ironically, for her healed up beautifully, but the graft site keeps breaking down because it's where she wears her bra that breaks down, and it's where she does her gardening and her housework. She's 85, very active now that we've taken her off the antihypertensives. And that was her plea. Just when I told her I was coming here, please remind people to review the drugs they put patients on. So the concerns about them, they all had different needs. They all had chronic illnesses, maybe contributing to what happened to them. And with my lady, the last lady, prescribed medication and lack of review. So I'll quickly say, elderly patients, when we assess them in trauma, in A&E, it's the same as anybody else. I'm not going to go through that because you're not really interested in that. You just want to know, what dresses do you put on a minor burn? Because you all talk like that around here, don't you? So documentation. When I see someone, first of all, I will write down the size of the burn, what it looks like, are they allergic to anything, all those normal things, medications, anything significant in their past medical history. And that does not mean, have you ever been in hospital? And they go, wellness. I was in hospital. I had my ingrown toenail out in 1942 in Cottage Hospital, but it's not a Cottage Hospital anymore. It's a nice block of flats. Have you been there? Have you seen it? You've got to get them to answer the right questions. So, is there any breathing difficulties, blood pressure problems, history of cancer in the family, those sort of things. Otherwise, they'll wander off and you'll never get them back into the way you want them to be. What did they last eat or drink? Particularly from a point of view, we were going to operate, which we do take quite an aggressive early approach with burns elderly patients. But it can they recollect how much they've eaten in the last day? Have they actually eaten anything? So it's part of your general state, assessment. What events have led up to this injury or this burn injury or their illness that's contributed to them getting burned? So as I said, we're quite aggressive now. When I worked in burns 20 odd years ago, we used to take the slowly approach. Now if someone comes in and their burns mixed depth, we're more likely to be aggressive, take them to theatre, debride them, rather than the risk of infection and other problems from hospitalisation, length of stay, risk of infection. We take much thinner grafts because we know it's going to take longer to heal. But when you're working in general practice, community, if someone has a minor burn, look at what contributed to it. They may not need referral, but they may keep getting repeated burns on their arms, like me, until I bought gauntlet gloves. I know you think she's not demented, but she's a bit of a mad nutter. Look at their history, look at what they're taking, medication, whether it's legal or not. My friend works in Ireland, and what she says to patients is, do you take any medicines whatsoever? And they go, well, I've got my sister's tablets because she's got the blood pressure and I've got the blood pressure, so I've been taking her tablets. So they're not actually prescribed for them. So always ask patients, are they taking drugs that are prescribed from them or someone else in the family? Don't make assumptions it's their medication. Look at the date on the bottles and where they've come from. Because they may have had them for 20 years in the drawer and the name of the chemist is blurred. They've never taken them in their life, but that's what the doctor prescribed them 20 years ago. So they've got repeat prescriptions but never taken them. Look at the high-risk activities from cooking, smoking, bathing. You know, are they safe when they go in the bath? Refer them, if appropriately. They might need a falls risk assessment. You know, you might need to look at the same things that cause patients to get burnt. It's the same that cause patients to fall over, like loose carpets, unable to do the stairs. If you listen to The Archer, Joe Grundy got injured last week over loose carpet in the hotel. See, sad bastard has no life, looks after patients and listens to the Archers. I mean, what can I tell you? So, how would you define a minor burn? There are key features which I'll take you through quickly. It's about size. I know men say size is important, but it is in burns, all right? 1% is the patient's palm of hand, fingers closed, is a 1% approximation of their whole body. So if a patient has less than 3%, that's a minor burn. If it's a child, it's less than 1%. So it's the patient's hand, not yours, all right? So generally, we'd accept about 2 to 3% in an elderly patient is a minor burn. That's by size. Depth, it would be superficial to partial thickness. So if you looked at the wound bed, it would be pinky red, there's capillary refill, it's painful. This is not complex scientific, you know, it's really out there. It's nothing, I'm not teaching anything new. How did they get burnt? Was it a scald? Was it a flash burn? That's a short exposure to a high heat. Or was it brief contact with a hot surface like radiator or a cooker or the rails or the things in the cooker? Now, in my dreams, all the men would look like this who come into my care. But they have to be, patients are generally fit and well if they have a minor burn, no serious comorbidities. Well, I'm already telling you that most elderly patients are over 60, they've got underlying medical conditions. So usually minor burns reflects over 5 years old and under 60. But you do get some fit 70 and 80-year-olds in health, I mean, not looking for fit. Have they had good first aid? And by that we mean cool water, minimum of 10 minutes, maximum of 20. Now, when I teach at the universities, I always say, what's the deliberate mistake in this slide? And they always say, you're helping a man. Sorry, that's just... But it's actually removing the chain that's in the way if you think they've got a scald. So if they've got anything, like if there's an elderly person who burns their hand and she says, don't take my wedding ring off, it's been on there since Albert put it on in 1942, it's much easier to take it off now while it's not swollen than actually cut it, because you're breaking the band. I'm a bit carey-sherry here. If you break the band, then we have to get our chaplain to come back and bless it and put it back on, you see. So I can be quite kind. No other issues like involvement of face, hands, genitalia or feet, because those are key areas that make a small burn quite complex to manage. And they shouldn't have any evidence of inhalation injury, any other associated injuries or severe pre-existing medical problems. And if it's not bad enough that he's been burnt face and hands, someone's put a blindfold on him, so it scares me even more. Right, hello nurses. Minor burn care comes under nurses. It doesn't need a doctorate, it doesn't need prescribing. So assessment drives your management. That's a title for an assignment if you're doing a wound care essay, anybody? All right? If you don't assess your patients well, your whole plan of care will go awry. It just won't work. We want to clean the burn. This is not first aid. If you've got a burn, we want it cleaned. Even if someone's got a 98% burn and only their big toes sticking out, it better be a clean toe with a nice trim nail. That's my philosophy. So, remove all dead skin, de-roof blisters, which we'll talk about in a minute, because that's the other question we always get asked. What dressing can I put on and can I pop the blister? If the area is sooty or it's a couple of days late, wash the area, because they'll be dry, exudate, and it doesn't look very nice. Clean the water with soap and tap water. It's not complicated. There's plenty of evidence, Cochrane database and everything else about cleaning traumatic wounds with tap water. We are very keen on documentation. We do use lots of photography, and we now have telemedicine in burns, so that all burn services with their A&Es, you can see a burn in A&E, shoot us an image, and we can go, yes, we'll see it, no, we don't, or Anne will go and see it tomorrow. So it's one thing that we must big up that we have now in burns, that we have telemedicine. And in telemedicine, you need to remove the blister, because we all know what blisters look like. We want to see what's underneath the lid of the saucepan to take the lid off. This is in burns, all right, not in diabetic foot or whatever else, or pressure ulcers, but in burns, if it's got a blister, get rid of the blister. I won a Toblerone in the infection prevention competition last year for this. Water and soap help. Wash. The solution to pollution is dilution. The reason why we have bacteria everywhere is nobody washes wounds, washes the patients. And that's why I'm really advocate therapeutic showers and baths for my patients. So, wash them, we'll manage the blister. If there's grit or foreign body in the wound, we want to get rid of that. There's a plethora of dressings to choose from. Make sure that the tetanus is up to date, because we still see burns as tetany-prone wounds. We want them to have rest and elevation. And because they're women, the majority of my elderly patients, I always say that they need to be sat down and treated like a queen. If it's a man with a leg burn, I teach him he can still hoover, do the high dusting, because men were put on this earth to suffer. Women, we have babies and children and periods. You lot have an easy life. So we want to manage their pain. And because they're elderly, most elderly patients don't get good analgesia, because people worry about addiction or sedating, and they don't give them enough analgesia. We want to make sure they eat more. I just say to my patients, eat, drink, make me happy. Next week when you come in and you're as big as me, you'll be healed. We don't want them to have supplements. We want them to have good food, little and often. So our dietitian for the community has done some wonderful guidelines in Buckinghamshire, and it's about how to make more nutritious meals and to get away from giving them 40 sips and 40 mLs and supplements like that. And good infection prevention and control measures. We know, excuse me, with my tissue in my hand, that these are the main vectors of infection. I don't do aseptic technique. I wash my hands, I wear gloves and apron, I bath my patients, I am clean. It's in their environment. I don't fiddle arse with forceps and scissors and all that. I have Infocare, I have wipes, and I wash my patients. And I wash their wounds and I dry the surrounding skin. It's not aseptic, it's just clean. So if the patient has simple redness, you want to cool the area to reduce the depth of burn, and for pain relief, because that's the first aspect of pain relief, is cooling the area. You might want to cover it. Now you might want to cover it with cling film and send them to hospital. You might want to cover it because it's on an area that's subject to friction. So if it's a man and it's on his torso, you might want a film dressing or a hydrocolloid just so the clothes slip up and down. If it's on the shoulder and someone like me, I'll use myself as an example. I have done my diversity training, but it's had no impact, as you can tell. I'm a big bird. If I couldn't wear my bra because I burnt my shoulder, my droopy swingers would be down here and I'd have to kick them out the way as I go downstairs. So I need a nice foam dressing. It is not for healing, it is just to prevent shear and friction. So think, for your patient's sake, is it comfortable? Will that help them? It's not for wound healing, it's to prevent shear or friction. We want them to drink more, we want them to have regular oral analgesia. Over-the-counter medicines are fine for burn management as long as they take them regularly to get the pain under control. We use lots of moisturising agents like aloe vera gel, E45, anything that moisturises. We don't want astringent things like, what's that horrible stuff, calamine or whatever. Review at day 2, once the redness, pain and swelling starts to subside, and you'll see it hasn't blistered, it's gone, it's healed, they're fine. So then we practice scar moisturisation, which is just application of things like E45 or Cetrabens. Talk about how to prevent the burn happening again, and talk about accident prevention, because this should be the first alert. You know, they've had a simple, red, small burn, but they may contribute to having a bigger burn if you don't put some interventions in there to prevent them being injured again. Superficial partial thickness burns, as I said earlier, expect to heal within 2 weeks. Partial thickness may take 2 to 3 weeks. But if that burn isn't pinky red and the capillary refill's slow, it appears white, leathery or hard, you may need to refer them because they're not partial thickness. And the burn wound is quite dynamic and changes over time. So to begin with, you might say, this looks partial thickness, however, we will review you on a regular basis, and if it changes, we may have to refer you. All right, so always be honest with your patient from the start. Everybody wants to know, what's the world's best burns dressing? Well, the same as anything, you need dressings that promote moist wound healing. So that's from a literature search and expert opinion. And in wound care, expert opinion normally means we go off to a hotel with a company, we sit down, it's called beer and sandwiches approach, we all talk about what we do and then we write it up. That's where all the position documents come from, isn't it? Not that I'm old, bitter, cynical or twisted. So the first few days you want a cheap, safe dressing that can go on, doesn't stick, that you can take off after a couple of days and assess the wound bed. So use whatever you have on your wound formulary. I'm not that fussed. Paraffin is used a lot in burns and plastics because it's cheap. We leave it on maybe for a day or two and we whisk it off and throw it in the bin. However, it's going to be something longer than 3 days. You don't want a paraffin dressing because it gets caught up with the exudate and it hurts when you take it off. Our patients are rounded. Dressings are usually square and flat. Make the dressings fit the contours of the patient. So if they've burnt their arm, don't dress it that way. Dress it distally to proximally to fit the contours so they can still move. Make sure the dressings don't slip and leave the patient stuck to the bandage because that's really excruciating. The first week post-burn, it's traumatic inflammatory response, so there will be a lot of exudate. So you want to make sure they have sufficient secondary dressings that you can pad or change the dressings regularly, the outer dressing, without disturbing the underneath. Explain to the patient this is normal because they might be frightened about the amount of exudate. Tell them to expect some exudate, and it may be funny smelling because it's come out of their body. So you say to the patient, smell that? They go, yeah, it smells funny, and that's normal. If it smells and it makes you feel sick, that isn't normal. You must come back or contact the hospital or the clinic. Yes, silver does have a role in burns, but not on everything. We don't put silver on everything. If it's superficial partial thickness, you can spit on it and it'll heal. I'm not advocating that you spit on your wounds, and in 20 years' time, they'll say, we have this new product. You make the patient spit on it, and the growth factors will help them heal the wound. But really, superficial partial thickness wounds will heal on their own, as long as they don't get infection or pressure. So review them in a couple of days, and then every 3 to 7 days as you need to. As I said, anything that's taking longer to heal than you think, you should refer. So there's lots of passive dressings. You can look at hydrocolloids, hydrofibers. I'm not here to promote one product about anybody else's. You have a choice just to, as I say, put pads or foam or gamgees or whatever. We bandage and tape, and often because our patients have burns in awkward areas, we make them little vests or trousers or pants out of Surgifix or Tubifast just to hold the dressings in place. It's easier to dress fingers and toes separately, but we'll talk about hands in a minute. The key factor with blisters is it was the question we got asked the most, so our network wrote a guidance or recommendations because we knew that blisters are a problem. They impede the burn assessment properly. It restricts movement, particularly of joints, and we want our patients to resume their full pre-burn level of function. And that bacteria that can breed in that fluid will increase the risk of infection. Now, you may read the literature that says, oh, yes, there's wonderful growth factors in... Yep. Wendy went over. I'm nearly there, Mike, honest. So we want to improve the patient comfort, relieve pressure, and clean the wound bed. So our statement's on our website. If you want to back up your practice, it's got the references and everything on it. So we do say blisters over the size of the patient's little finger now can be deroofed. How often you do the dressing, again, depends if there's bacteria there, depends what other products you're using. But any cellulitis, then you would consider oral antibiotics. Otherwise, we don't promote antibiotics. As I said, you can always use any antimicrobial, but ring us for advice if you are worried. So, once they've, over that first week or so, we then swap to other dressings that can be left in situ for longer. All facial burns should be discussed does not mean you have to refer everybody with a burn with to the face. We've had patients with the size of a Smartie on their nose sent to us because it's a facial burn, it must go to burns. Decide what's best for your patient. Do they want, have they got psychosocial issues about having a facial burn, or is it small enough to manage at home? Hands can be put in plastic bags, but they need changing regularly. So it may be easier to actually dress them with non-adherent products and wrap each finger. But the important thing is mobility and analgesia and elevation. We don't give prophylactic antibiotics. That's definitely a no-no. And ongoing care, we want regular dressings, regular evaluations. You can ring us. You can consider contacting the burn service for outreach if they've got it, which most services now seem to have. We want them to have regular pain relief. As I said, elevate. use soap substitutes like aqueous cream. I promote the use of Dove because Dove was actually created for burns patients in the 50s. And it smells nice, and they have sensitive Dove, so the patients feel good, they feel better, it doesn't have a smelly wound. Increase their appetite, increase what they eat and drink, increase maybe having a vitamin supplement, plenty of analgesia, moisturise once they're healed. I'm glad somebody mentioned itching, because a lot of our patients with partial thickness burns who are elderly get severe itching, and one of the best things is actually gabapentin. But to start it, you have to start off, you increase the dosage over 3 days. They often get faint and dizzy with it, so it's one of the things that needs careful monitoring. Involve the family. If there's signs of infection, refer. We will see patients at any time, so please, any concerns as a healthcare professional, refer to a burn service. This is normal inflammatory response. This is because we've been using a particular product that makes it dry and brown. It's not infection. It doesn't need referral. It doesn't need antibiotics. That obviously is a dead giveaway because they've already marked out the inflammation with the pen. Yes, that would be referred and we'd give them antibiotics. This is also on our website, which you can download and copy and put your own information. It's for minor burn injuries, and our burn care advisors in the southeast, London southeast, devised this so that everybody gave out fairly generic information. I'm coming to the end, Mike, honest. So the most important thing for our elderly patients is Age UK. They have a home safety checker. So get your students, again, they can go and get this information. They can download it from the website to utilise, to educate. Look at the European Network for Safety Among Elderly, and look at what fire prevention you can put in place. And most important, don't smoke when drowsy, don't smoke when oxygen therapy, wear safe clothes, get thermostatic taps, look at the home heating, use a fire guard, encourage patients to check their wiring safe, and educate everybody that you can, because the best management for burn injury is actually prevention. And I thank you for being invited and for listening. Thank you very much.